see. Okay, there we go. All right, so this is a cute little case. So this was a case I was asked to look at for a young patient who presented with chest pain in an outside hospital and was told she had a mediastinal mass. And I think all of us would agree that's just normal thymus, and I was not worried about it. But what caught my attention was when I was looking at the rest of her chest, I noticed her carina looked kind of funny. And you may see already we're usually used to seeing the upper lobe bronchus on the right take off pretty early, and we don't really see that. And then you can see there's nice symmetry here. And then we have what look like two morphologic left lungs. I'll show the vasculature here. You can see there's the arteries. So these are hyparterial bronchi there, and we can make a coronal. And you can see that indeed this patient has bilateral hyparterial bronchi. So this is an incidental case of left pulmonary isomerism. There's normal situs in the belly, purely incidental, but kind of a neat finding where you have morphologically two left lungs. I've never seen right isomerism. I suspect it's probably associated with a lot of congenital anomalies, and that's probably why not. But I see this every so often. So it's just a reminder to trainees, you got to follow the airways out and always look for that normal branching pattern. So just a little incidental finding. This is a patient who was in a motor vehicle crash, pretty high speed, and this is the chest radiograph. And you can see there's a lot of mediastinal tissue. It's really hard to clear the upper mediastinum. There's some atelectasis that we see there. And so the patient went on to get a CT scan. And the area of interest, there's a hemothorax here. You can see there's a retrosternal hematoma. So there's some fractures. There's a sternal fracture. There's a couple of things I want to show. Well, first is the hemothorax. So initially looking for the rib fractures, if you look just at the bones, you won't see any. But if you look anteriorly here, you'll notice there's a disruption of the rib cartilages. And this can actually cause quite a bit of destabilization of the chest wall. You can see there's multiple levels where these are fractured and dislocated, quite a bit down here we can see there. So my experience with these, we get a lot of trauma transfers from multiple regional hospitals out in rural Wisconsin. And these fractures are often overlooked. And so the clue to me when I first saw this case was the extent of the retrosternal hematoma for a sternal fracture tracking that far laterally, but also the presence of a hemothorax without a clear source elsewhere. But further down, there's another interesting abnormality. And if you look at David, I know, loves the diaphragmatic crura. So it's one of the things I always like to look at too, because it's been drilled into me over the years. But if you look at the crus on the right compared to the left, it's very abnormal. It's very thick and irregular. And then further down, you'll see we actually have a little bit of contrast, extravasating, so active bleeding. So this is a crus hematoma with active bleeding. They did some delayed imaging for the abdomen, so I pulled those, and you can see that the bleeding, you don't see it on that series, but a little bit of it's still there. They ended up doing some abdominal surgery for some minor bowel injuries. You can see a little stranding at the root of the mesentery there. They didn't repair this because it sort of was auto-tamponading itself, but I've now seen a few diaphragmatic hematomas. They always seem to form right at the crus, and the ones I've seen have always been associated with mesenteric injuries, and of course you'd have to worry about a pancreatic injury or any sort of vascular injury there, but I have not seen one before with active bleeding. So that's that case.
That's fascinating.
Yeah, so got to remember to look down there because it's often at the border, especially if you're in a subspecialty practice where you split up everything. So that's where we overlap with the abdomen, but the diaphragm, in my opinion, is part of the chest. So I take responsibility for it. This is a fascinating case. There's not a lot of exciting imaging in the chest, but this is a patient. He was a liver transplant recipient about a year ago who was developing some fatigue and other symptoms, just not feeling malaise. So they did an abdominal CT, and they noted all of these low attenuation lesions in his liver and his spleen. And then I think there's a little bit of stranding around there, but that may just be related yeah, in the sort of the fossa there. But what they also noted were some lytic lesions in the bones. You can see there's one there in that rib, and that's really the only chest finding of these lytic rib lesions. So of course they were worried about a malignancy, a PTLD. They did some other neuroimaging, so I just grabbed a couple sequences. Hopefully I can remember where the abnormalities were. They weren't the most obvious. I think there were some frontotemporal lesions, but this patient had oh no, it was calvarial lesions. There's one there. So this sort of peripherally enhancing calvarial lesion. Some more of these bone lesions. And so they were worried about PTLD or some other malignancy. So they ended up biopsying, I think, one of the liver lesions,
No,
if I
no
remember.
chest CT, Jeff?
No chest CT,
No nodules?
no lung nodules.
Hmm.
So they ended up biopsying this, and they recovered Bartonella henselae, so
Wow.
cat scratch. And then I found you can always rely on the infectious disease experts. A nice note: the patient had gotten a kitten 3 months ago and had multiple scratches that drew blood. That was his exposure. So this is cat scratch disease, but it's a case of disseminated. But I had no idea it caused lytic bone lesions, but that was the only chest finding. I looked for the lung nodules, there weren't any, so nothing exciting.
I thought you were gonna go sarcoid there.
Yeah, that's a good one. PTLD was a thought given the spleen, but nope, it's Bartonella. The
See,
only case that I've ever seen. And then this last case was just shared with me. Oh darn it, the PA didn't come again. Our packs were in exports. Anyway, this is a young person, like 3 years old, presented with this massive mass. I'll show the coronal CT in the right hemithorax. Something we don't see much or ever in adults, really. But when you see a really big mass in a very young child in the lung, you always want to think about a pleural pulmonary blastoma. And you can see this one is sort of mostly solid. There are some cystic components, but this is a type 3, which have can be the most aggressive. And this one actually, if I remember, had bone mets, which I didn't realize these metastasized to bone. Where was that met? There was, I think, a vertebral body met. But yeah, there's some in the spine, for example. We see that one there. But when you see a really, really big chest mass in a young child, you think pleural pulmonary blastoma. The type 1s are mostly cystic and can look a lot like a CPAM. I've never seen one, so I don't know what that looks like, but in my reading about these is the type 3s tend to be the more aggressive ones, but this one responded to therapy. It's an older case, and then they can treat with chemotherapy because they are fairly responsive to treatment, but they can metastasize to other sites, but predominantly bone in this case. But and if this were an adult, then I'd start wondering about a sarcoma or a fibrous tumor of the pleura that had transformed into a more aggressive one. But pleural
And,
blastoma in a child.
and Jeff, what was going on with that left kidney? Because I don't know which type, but I know they can be associated with multilocular cystic nephromas. But was that just a little bit of
I think it's just hydronephrosis on both sides.
hydronephrosis? Yeah. I don't know if it was type 3 or what. I just vaguely remember that association.
That I didn't.
Another reason for a large mass in a kid is a peanut, nerve.
Yeah.
Oh yeah, like a
kernel tumor. Famous for being huge.
And primarily arising from the lung.
Well, no, but they could. Yeah, they're often chest wall or pleura, but
okay.
You can't tell.
Yeah. This one's pretty convincing for the lung just because it replaces most of the lung. But yeah, it's a rare tumor, so it's interesting to see one, but yeah, probably never see one again. Okay. That's
Ewing sarcoma also could look like that.
Okay.
That's the peanut thing. There's a name for it in kids that escapes me right now, but Ewing and peanut and this name in kids are all the same histology, I think.
Yeah, I think they lump them together. And there's the Askin tumor when it arises from.
Askin tumor is that's the one.
Yeah, they're all the same. Yeah, they're that Ewing sarcoma family or whatever they call it, Ewing family of sarcomas. Small round blue cells. Okay. Who would like to go next?
I have two quickies, Jeff. One of which resonates with a case you showed recently. So I don't have a chest radiograph, but I have a scout view to show you with a lesion here above the right hilum. And here it is on CT. This case was shown to me about 20 minutes after the conference from a couple of weeks ago, which was very good preparation. So here's our lesion. It's an elongated branching lesion above the right lung hilum, and there's some rarefaction of lung peripheral to it. You can see the lung tissue is a little bit rarefied out here in kind of a wedge shape beyond this thing. And then it has this high attenuation component centrally. So it's not as spectacular as Jeff's case from a couple of weeks ago of a mucus plug in ABPA. And evidently it's aspergillus in the presence of in the mucus plug that is busy gathering up minerals. So aspergillus is iron avid, so this could be partly iron. Sudhakar said that it was supposed to be manganese. It's probably iron, maybe it's manganese, and there's probably calcium in there too. But we know that aspergillus does try to gather up iron. I think that's one of the reasons why some of the acute phase reactants like transferrin are elevated to fight infection, probably because they want to sequester the iron and keep it away from organisms. Not just aspergillus, but some bacteria are also iron avid. So I suspect that this is probably iron that gives it the high attenuation. But this is allergic bronchopulmonary aspergillosis. The pulmonologists were very concerned about cancer, and they got a PET scan, and it shows that there is just a twinge of uptake here, nothing scary. And on the MIPS, you can see just a small amount of uptake here. No, not to say that there's not a tiny little tumor that's the cause of this mucus plug. So bronchoscopy is important to make sure there is not an obstructing tumor. But this is attributed to ABPA, and I don't have much history on this person. It's a case from the VA, but I'm hoping to get some history and see if there was a background of asthma in this person. But Jeff's case from a couple of weeks ago had a number of these very high attenuation mucus plugs. I just got one in this case, but this literally occurred within minutes of the webinar when Jeff showed that case.
It's interesting
Okay.
that yours
David, are there any
that one.
airway abnormality away from it in the lung, separate from?
Not that I saw. Did you see something?
Okay. No.
I think there's some bronchial wall thickening up here and on this side as well. So I think that there's probably a history of asthma in this person. That's the typical setting. So I'll try to get that.
Yeah. Yeah, the more you scroll around, the more I think I can see bronchial disease. That's rather diffuse. Right. It would go along with that, yeah.
Maybe they should have done MR spectroscopy instead of PET to see if they could tease out manganese versus iron.
Well, I tried to, I tried to look up, mineralogy and mucus. Especially, I couldn't find anything, but I probably just don't know how to look for something like that.
I've read manganese before too. I've heard that. I've also just read metal salts in general. Yeah,
but I think, a lot of times that's just lore that's being passed down, but you don't know what study ultimately was responsible for that. We used to do, our pathologists used to do electron beam, studies of these things, and I think they could identify all the elements by bouncing electrons off of in some special scanner. But I've never seen a case here that's gone to pathology where they might have had the opportunity to do that locally, at least. Okay, so here's another case. I'll show you this woman who has, on this radiograph from September, had some ill-defined consolidation in that left base. You can see it posteriorly, so it's real. So it looks as if it could be aspiration or pneumonia. And then a couple of weeks later, I think this is after treatment, she had a CT scan, which I'll try to show you the non-MIPSy version here, which shows what looks like a resolving organizing pneumonia with kind of a peripheral rim. of consolidation, a more loosened center. So that kind of circularity here looks like those crop things that used to show up. Those, what do they call those, crop circles or something like that, that were attributed to UFOs or something.
Yep.
So maybe UFO activity in the lung there. But she continued to be ill, and she came in more recently, this is the beginning of November, with more consolidation in that left base. And here it is a day or so later, and you can see that again, there's this consolidation down here. Things got much worse suddenly. So let me skip ahead to a radiograph.
Hey, David, on that lateral that you just had up, was
Yeah.
that bones anteriorly, or was there more stuff in the lung in the retrosternal clear space?
There was stuff in the retrosternal space, as you will soon see. So here's a CT scan at the time of this diffuse lung disease, and you'll see that there's a ton of ground glass here, and a lot of it is trying to be peripheral. It's got very nice reticulation on top of it, so a nice crazy paving pattern. And here's that lesion that we saw before in the left lower lobe. It's been re-outlined now, that its periphery has been exaggerated, so it really has that organizing pneumonia look to it. So widespread ground glass, a lot of peripheral component and organizing pneumonia component to it too. Rapid response to steroid treatment. Here's a couple days later, you can see dramatic clearing. And perhaps you would like to see her sinus CT. I think she's had some sinus surgery. My mouse has disappeared here. I don't know how to bring up this CT without a mouse. But she does have sinusitis. She also has a peripheral eosinophilia, and I don't know that she has heart disease, and I don't know about peripheral neuropathy. I need to do more work on her history, but she carries a diagnosis with her peripheral eosinophilia of ABPA. So eosinophilic pneumonia here, presumably, which often has an organizing pneumonia pattern to it, has a nice peripheral distribution, and the sinus disease that goes with that. So the things that would nail it would be neuropathy, which is attributed to the vascular supply to the nerves, and if she had heart disease, that would be another point in establishing this diagnosis, as opposed to other eosinophilic pneumonia conditions. Okay, so EGPA with this rapidly progressive and variable eosinophilic pneumonia. Okay, guys, that's it.
That's
Wow.
a good one. Okay. So who's next?
I'll show a couple.
All right.
I may have to sneak back to the reading room in a few. All right, I've got a couple of balloon pump cases. You know, we still find these to be perplexing sometimes. And I'm going to start with this one. And you can see this person's obviously got some cardiac issues. They've got a pulmonary artery catheter in. And you notice the proximal portion of this intra-aortic balloon pump is slightly more horizontal, or almost even angled inferiorly more than it should be. And you can, in this case, actually see the distal portion as well, which is why I include both of these. Now, I think the smallest balloon pumps that we have here are 23 centimeters in length. Most of them are like 25 centimeters. And what's frustrating, and you may see the same thing, is like they usually just report them in terms of the volume of air that they hold. So this is a 40 milliliter one, which of course is then influenced by the diameter, how long it actually is. But you can see if you just measure a straight line, it's only 20 centimeters. So that's too short. So something is not quite right here, at least makes me a little nervous. And then in this case, though, you can see this is actually a right axillary approach. And so I was getting a little nervous when I saw this, because I was thinking it was probably too far into the aortic arch, proximally, and perhaps covering up the subclavian artery, the left subclavian. But you'll see the CT was done around the same time. Here you can see the brachiocephalic approach, and the the distal marker is horizontal, but it's in the distal arch, so it's beyond the left subclavian. So this one's actually okay, and it's just the curvature of the aorta that accounts for the rest of the discrepancy in length. So this was still about 25 centimeters if you do a curved MPR and lay it out. Now, this person's been here a while. I'll go forward a few days. Here you can see the same horizontal configuration. And then I think it's perhaps this one. Yeah, and now you can see that it's migrated a little bit more proximally. This marker, you can see that the balloon is inflated in the arch. And as much as I try to even do some sort of curved thing, you can see the distal markers right here, and that's only about a 14 centimeter distance. So this is one where we called clinically, it seemed like it was too proximal as well. They actually advanced it a little, and they advanced it a little too far. This is just adventures in intra-aortic balloon pump positioning. It's around the level of the left main stem bronchus, and you'll see here that now the tip is just below the main stem bronchus, and it extends inferiorly below the superior mesenteric artery. And he has the subacute, the left one was a little bit older than the right, but these acute on subacute or acute on chronic retroperitoneal hematomas. And they actually removed the balloon pump and put an Impella in. But this is one of those ones where it's nice to, if you can see both markers, at least know roughly how long it is. And so this is kind of just, this is the first one which sets the stage for this one that I think is actually more impressive. And let me make sure I get the right image here. Yeah, this image. So this one, you can see there's a marker that looks like it's over the arch, and the distal marker is right here. And so there's no way you can get 25 centimeters between here and here. And looking to see where this one was actually inserted, you can see these clips are from a left axillary insertion. And check out this CT. Let me make sure this is the correct one. And yeah, so this CT was done around the same time as that radiograph because somebody noticed that. And you will see that the marker is right here in that arch as it was. But the balloon, and I suspect this is because it's put in on the left side, the balloon looped in the ascending aorta and comes all the way back up. So it's starting here, going down into the ascending aorta, coming all the way back up, and then into the descending aorta, which accounts for the short course when you look at it on just this single AP view.
Do you mean
So
that the balloon is, the sausage is kinked?
Yeah.
Holy
Right, because
cow.
the balloon is starting here, going inferiorly into the ascending aorta, so coming proximally, and then loops back around right here, comes back up into the arch. Because you can see this is the portion of the catheter going into the left subclavian artery. Yeah, and then it comes down the aortic arch. And so, the more I look at these things, the more I hate them, because it's just so hard to tell. Like, here's an example. This is after that, and they've repositioned it. So this looks more appropriate, but we don't even see the distal portion. And I think this patient ended up getting another one. And now you can see, we can see proximal and distal. And this is going to be, I think this was like 23, or still a little too short, but I think a lot of that is just curvature of the aorta. It may still be in the arch, but looping around. And when they did this follow-up CT, it's still in the arch. So it's still a little proximal because it's still covering up the arch vessels. But these are just tough cases.
So
But,
there's a trend in our place to go to Impellas rather than intra-aortic balloons. So we're not putting in as many intra-aortic balloons as before.
I like that. I mean, we're still doing them, but I like that approach because, especially clearly these weren't designed by radiologists since they're nearly invisible. So,
Travis, with the axillary approach,
Yeah.
intra-aortic balloon pumps, what I think I've noticed is the little metallic markers in general tend to be a little tilted. Like they're not like straight up and down. Is that something you noticed? Just me.
Yes, I agree. But like if they do position them into the descending aorta, like this other one that I showed you on that last image, I mean, this is headed down the descending
Yeah,
aorta,
yeah,
so it's more vertical. Yeah.
Yeah,
But you're
no,
right.
yeah,
Yeah.
yours are
And that's-
definitely abnormal. I'm just saying in general, if that's it's a clue that they're axillary.
Yeah.
It's a little tilted.
And that's
But I
why
think
yeah. Go ahead.
I think the marker's a little bit shorter. That proximal marker is shorter than the one that's at the tip. And then, some of the ones have a fainter extension past the dense marker
Mhm.
that tells you that's really the tip and not the proximal marker. But I think so it's possible that the thing looks tilted because it's just shorter.
Well,
more shortened.
There,
Okay.
I was looking at a table that has the sizing, and like I said, it just refers to them in milliliters, not the length of the balloon portion itself. And the one table I was looking at did describe the length of both the proximal and the distal metallic tips as well. I didn't notice a difference. Usually they're 5 or 6 millimeters. I'll have to
Okay.
look and see. That's an interesting point.
Well,
Yeah.
and I may be wrong about it, so let me know.
Yeah, I'll look at the table again. And then I'm just going to show this one. This is a perplexing case. So this is a patient who last summer this is a biopsy proved squamous cell carcinoma of the lung. Lungs otherwise look okay. There's a few little additional nodules in the right lower lobe next to that, and not much to make of that. Then let's see, fast forward a few months, and you'll see that nodule has decreased in size. They've been given immunotherapy. They've been on durvalumab with, I think they got chemo and maybe radiation as well. But so that thing is trending in the right direction. All those other little nodules went away. Then in April, it starts to develop pretty extensive bilateral upper lung predominant nodules. And a lot of them you can see are clustered along the fissures here. And they're in the upper lobes, and then they're also in the right lower lobe where that primary tumor was. And I think one of the reasons she got more aggressive therapy is she did have a subcarinal and a right hilar node that were positive as well. So thinking maybe metastatic disease at this point, they do a bronch, it's negative. Oh, come on, trying to get both of these up side by side. Fast forward to May, things are getting a little bit bigger. And this may have been the time of the bronch, since the nodules are increasing in size and number. Certainly a little bit worrisome. And I'm gonna have to stop the syncing here.
That sinking feeling.
And let's see, this is May, this is June, still there. Not too much change. They're very solid, again, studying fissures and whatnot. Then this is the one where they continue to get a little bit worse. And now there's even a little bit of, maybe some septal thickening, upper lobes, still asymmetric, right greater than left. And did another bronch negative, go to surgical lung biopsy. And what do people think?
Sarcoid.
Granulomas
Yeah,
on KZ8.
from durvalumab.
Yeah, that's what I thought too, after they'd had the 2 negative bronchs. I mean, obviously at first you're worried about Mets, especially since it seemed to be more concentrated in the right lower lobe where the primary tumor had been. It was not sarcoid-like reaction. Any other guesses?
Fungus?
No, it was not infectious.
Hmm.
It was all Langerhans cell histiocytosis.
Oh no.
Had the patient
Yep.
had the patient quit smoking before? Because or did they
She
restart
was-
smoking, or was it the chemo that?
Well, I don't know. I know she was smoking. There was no comment of whether she stopped and restarted. But she was smoking, and I have looked, and I can't find any sort of durvalumab or other immunotherapy associated Langerhans. Obviously, we've seen this recur after treatment when patients start smoking again, to your
Right.
question. But
I think it's been described in patients who smoke who get chemotherapy.
I'd love to see that, because obviously, I mean, and not saying this shouldn't have gone to a surgical lung biopsy, because certainly it should have once they had several negative
Right.
other biopsies and it was getting worse. But at no point in time does any of this truly look like classical Langerhans cell histiocytosis. But
That's interesting because I had the same case probably earlier today, but I'll have to go back and review it. But it was exactly this. It was a patient with lung cancer with all of a sudden numerous new punctate nodules, which I assumed were Mets, but I'm gonna have to reconsider now.
well, and I think, you know,
Good.
especially when it's asymmetric like this, it's Mets
Yeah.
until proven otherwise, and sarcoid reaction certainly, you know, up there too.
Yeah,
But
I
all right.
was thinking it didn't make any sense for miliary disease, so miliary infection. So I thought it was Mets. But I'll have to look at it again.
That was my clinical conundrum for the week.
That is really odd.
All right. Thanks, Travis. Okay, let's see. Howard or Peter? We should have time for both of you, no problem.
Okay.
All right, oops.
Go.
Oh, there, hold on. Let's see if I can do this. There we go.
All right. A nice divulge the diagnosis there, but a nice example of a right-sided aortic arch, and the descending aorta is on the right side. Certainly the main pulmonary artery segment is large. And looking at this person's notes, some of them describe consultation for dyspnea, chronic dyspnea. And just one really mentioned the possibility of dysphagia. Here is an impression here. By description, a small pill, I forget how many millimeters they use, just held up transiently at that level. Here is the CT. So we have a right-sided aortic arch. In looking at the aorta here, we can see that it stops there. It's a bulge, a diverticulum-like structure here. And then, and I'll bring alongside the coronal, we will see that there is no patent vessel that connects the left subclavian artery to this region. Indeed, the left subclavian artery is filling across from the other side via the left vertebral artery. And here we can see the anatomy there. There's a little notch-like structure there, vertebral and subclavian. And there's a little structure here. And then you can see the degree of impression on the esophagus by this diverticulum-like structure. Now, the original, if I remember correctly, the original diverticulum of Commerell from his paper was aberrant right subclavian artery in his original paper. But they decided to operate on this patient. So the findings here are the unusual circumstance of right aortic arch with isolated left subclavian artery. And from my relatively brief reading, usually with isolated left subclavian artery, it may arise from the left pulmonary artery. But sometimes this does happen where it gets supplied from the vertebral artery in a retrograde fashion. But in thinking about the likelihood of a ligamentum being there and there being a ring, yes, indeed. And here is just a brief description of the ligation of what they described as a fibrous band going to the LPA. And interestingly, and I don't really know why, but they put a endovascular stent in here, distal to the aortic arch vessels, hoping, I think, to exclude this diverticulum-like structure and make it get smaller. I don't know if that's going to be successful as such, but they did see what they described as a band going to the LPA. And the only structure I think I see here, if there's a structure, it goes between here and apparently that diverticulum, I think, but I can't tell for sure right here. But an interesting case of isolated left subclavian artery and right aortic arch, like that.
That's so nice.
So,
I like
Travis, you
that.
made a comment about genetic abnormality that goes with this.
Oh yeah, I don't think she has anything like that. And I don't know why this pulmonary artery is so large, because the rest of the pulmonary arteries are fine and she does not have pulmonary hypertension. So, okay, yeah, someone mentioned a potential association with some genetic thing.
Yeah, just from like all the
Oh,
peds
yeah,
congenital
Travis.
stuff we've done, the 22q11
Okay,
mutations, often they'll check for those, especially in kids that have any sort of isolated or other arch anomalies like this.
okay, good. Here's a case, and if I'm correct, I think we've shown examples of this perhaps now a few times at the webinar. So motor vehicle crash, high speed, two vehicles heading into each other. And here we can see in the distal descending aorta in a couple places, those items. Let me bring it up on the coronal. And certainly consistent with presumably intimal injuries with a little bit of adherent thrombus. So minimal aortic injuries. And if I remember correctly, maybe Jeff or Travis have shown cases like this, also in this location, in the more distal aortas. Does that ring any bells?
Yeah, we've
Perhaps
seen
like
several
that?
cases.
Yeah. Now, this patient had a CT about 24 hours later, which I only became aware of today, so I didn't have time to match it in with this one. But these are still there, and I think it was about 24 hours between the two exams. And the findings are just like that. And of course, they're just going to not intervene, obviously, in that for that. So minimal aortic injuries, plural perhaps, with a little adherent thrombus. This is just a real curiosity. I'll show you the findings which are new from 2006. So the one finding in relation to the one lead is actually easier to see on the lateral, and I've shown one of these cases before. Here we can see in relation to this right ventricular lead that there is this. So that should not be there. That should be right there, closely applied to the rest of the lead. And on the frontal projection in this patient, this is the same phenomenon, except it's occurring in this location right here. So this is known to occur with a lead called a Riata lead, and it's termed conductor externalization of the lead. And you can see there were case reports of this going back some years. It turned out to be a bit of a scandal because I think the manufacturer tried to hide the occurrence of this abnormality for some time, but it is definitely a something. There may be some people that have some degree of externalization, but things still work. But of course, if a patient has a lead that's not working, then for this particular lead, that's called externalization, literal breakage down of the lead, and it comes right out of the insulation and it's basically broken down. So a curiosity.
Howard, is that a newer case? Because I remember seeing a couple of these here. When we heard about them, we did some radiographs to evaluate for these, but I haven't seen one in years. And I was just curious if they're still floating around out there, if they've checked them all, or if you're seeing any, or if anyone's seeing any requests to check these.
I don't know. This particular patient also had a problem with the generator, which was the subject of a recall.
Okay.
So the cardiologist, I think, knew about this, and they replaced, and that's how I came to see it, replaced subsequently both this lead and the generator as well. But I think the original reports were somewhere in that time period back then.
So Howard, I think this is an 06 case. Can you check the date of this chest X-ray?
This one is December of 2020, and this one is from before. And the lead disruption, the externalization occurred between the two.
Got it.
Yeah, over time between the two. So I don't know the timing of the manufacturer of the lead.
So, Jeff, you're right. I mean, this is something that occurred in the past, but that's because I think they've taken out most of these leads, or the patients have died.
Right.
But this is an old case, so this fits the time frame that you're talking about.
Okay. I just wanted to make sure there's not there's. I mean, because that's what I thought. They either took them out or, like you said, I mean, it's been not quite 10 years, but I just haven't heard them mentioned before. I haven't seen another case. I haven't had a request to look at any leads.
Yeah. Presumably, there are still maybe some patients out there with the lead in place that have a broken lead, but no one has discovered that because they're not symptomatic,
Right.
or they're not followed up closely, and telemetry is not done to necessarily evaluate the leads. Some patients will be lost to follow up, so there are probably some finite number of people that still have this particular lead in. So we might see that on occasion going forward, but I don't know about the number of leads that were implanted before they stopped being manufactured and distributed. This one is a very interesting case. It was kind of also a bit perplexing. So I'll just show you the radiograph of this young person. I forget the person's age, but I think he's now in his 20s. And I came across this in the context of surgery here, in preparation for and subsequent removal of the right lower lobe. So we have a lot of abnormality, obviously big cysts here. And if you look at the vessels in the lungs elsewhere, some of them appear to be small. So let me show you the corresponding CT. I think I can show you, I'll show you this one. And not that. Let's see, what do I have? Here we go. So starting from above, the lungs already look abnormal. I hope that folks can appreciate that we have mosaic attenuation, where there are areas of lung that are more attenuating than areas like this. And in these areas here, sometimes it can be hard to tell, but I think the vessels are a little bit smaller, but you'll see the mosaic attenuation pattern is very evident as you go through and look at the rest of it. And then the cysts as well of varying sizes and different locations. And here's the large cyst, but of course it's bilateral. So, what is this? So it turns out, and I'll show you in a moment, that there is a history that soon after birth, he was premature, I think. Let me just bring that up. And he then, at 5 weeks of age, he was really sick. And this is the history obtained from the family. So aspiration of fluid, RSV infection, several months on ventilatory support, recurrent pneumothoraces, and then eventually got over that, but still has symptoms, of course. So like a very strange occurrence. So when I looked at this, I thought, well, several things, to what extent are these large cystic spaces in the right lower lobe occupying most of the lower lobe really affecting overall respiratory function? And I'm not sure that one can tell that readily. But I also looked at the path report, and typically in this kind of situation, when the lobe comes out, they don't examine the lung to any detail. And I contacted my colleague, the pathologist, and said, I really see mosaic attenuation, and I think there ought to be findings of obstructive small airways disease in there. Would you take another look? And that was done. So let me make this black and white, because as you can see here, there were findings of obstructive small airways disease. And here are some images. So here along the length of a bronchus, that bronchus is pretty much scarred down to nothing. It's just a scar. Here's a bronchus. The lumen is small. Too much tissue between the epithelium and the outer wall. So this is subepithelial fibrosis. And in some other locations, more scarred airways, the pathologist also found this rather strange mucosal abnormality, which he described as mucosal papillary hyperplasia, narrowing the lumen of the airways a bit. But this is really actually very striking. So a person with that history that has got findings of obstructive small airways disease, fibrotic constrictive bronchiolitis, as well as these very strange pulmonary cystic spaces, or presumably related to that childhood infection. Can anyone recall seeing this degree of lung damage from a RSV infection, even if severe? I'm trying to recall. Certainly post-viral constrictive bronchiolitis we're used to thinking about.
Well, I wonder if the larger cystic spaces are related to either oxygen therapy or pressure support, sort of like a BPD light pattern.
Yep.
But
Like pattern for
and
many weeks, months of assisted ventilation and so on.
And it's hard to say if the small airways component is related or if it's from the RSV itself.
Right. It's really hard to disentangle,
Nice you got
but I think
pathology, though. That's a great example. And so it wasn't picked up initially on the the specimen.
right. I don't think they examined the specimen with a view to small abnormalities and subtle abnormalities.
And that's my understanding about constrictive bronchiolitis. It's easy to walk right by because you don't see the airway at all. It's just like your lower image there just shows it, the truly obliterated airway.
Yeah, yeah.
Howard, how much lung resection did he have? Did they was it a right lower lobectomy?
Yes, with difficulty, with adhesions and stuff, they eventually did a right lower lobectomy. That's right.
God.
Yeah. Yep, they did that, yep. All right, so kind of a curious case. I'm kind of pessimistic about his overall function. Is he going to get worse? Is he going to just have to live with this? But ultimately, of course, the only cure is a transplantation, right?
How old is he now?
In his 20s, I think, David, I forget exactly.
Got it.
Yeah. All right, those are my cases for the week.
All right, thanks, Howard. All right, Peter, you can go.
Can you guys see the screen?
Good.
Here?
Yep.
Okay. This is a quick one. So just a kind of a case that could easily fake you out. So here's a patient, and just looking at the heart, there's this pocket right here, and it looks like a little subvalvular aneurysm. But if you look, so the valve has been replaced, but there's a lot of calcium here, right around the annulus. So I've seen these a few times before, but it'd be always good to pull up a non-con And you can see that that's actually not calcium. That's not contrast, but there's actually hyperdensity there. So that's caseous mitral annular calcification, but it could easily look like an aneurysm, just because it has very similar attenuation to contrast. And a lot of times, there's just liquefactive necrosis of the mitral annulus. So that's a quick one. All of them are actually pretty quick. So this one is an interesting case. Young 19-year-old college girl, and she has pharyngitis several days, pretty sick, and comes in. Eventually gets admitted to the ICU with hypotension, but she also has a rash, and so I was called by the pulmonologist to look at this CT, and they told me that she tested, she had a positive strep test, strep antigen. So you look at this, and this does not, pneumonia is not the first thing. So basically the story is an infection, but this doesn't look like a pneumonia. Actually, it looks like pulmonary edema with septal lines, gravitas, very diffuse curly lines. So this is actually not strep pneumo. This is strep A, group A strep. So this is toxic shock syndrome. She had a scarlet fever-like rash also. So that combination, they diagnosed her with toxic shock syndrome, and I basically told them this is going to be permeability edema from toxic shock syndrome. So this is not actually a pneumonia. Actually, you wouldn't expect that. So strep. This is not strep pneumo, strep pyogenes. That's an example of permeability edema, and it doesn't seem like at this point there's any diffuse alveolar damage here. So you get edema, permeability edema without DAD, which probably this is down the line. I don't know. Hopefully it'll resolve.
Yeah. The nodal pathology is probably edematous nodes rather than
Right. Yeah, that's pretty impressive also. Yeah.
And although this patient isn't intubated, right? It's possible that the opacities in the dependent lung are simply just heavy, atelectatic, potentially so-called recruitable lung, rather than any separate pathologic process in the non-aerated portions of the dorsal lungs.
Mm-hmm.
Yeah.
And it seems like she did pretty well. This was from about a week and a half ago, and then she only had 1 or 2 follow-up X-rays. It seems like she did well after she was put on antibiotics and recovered well. She had good reserve also. No past medical history. 19 years old.
Could any of this be iatrogenic fluid overload to the soft tissues?
They did give her. They did try to resuscitate her with fluids also because she was hypotensive. So some of this, and she did have slightly elevated troponin and BMP, which might be from the actual from the exotoxin. So there might be some component of cardiogenic and volume overload here as well, but obviously permeability too. So yeah, you did give her some fluids. And the last case I found interesting because I don't see these here very often, but this is a 40-year-old patient. This is his initial radiograph from June. So he, 40-year-old, just came in with chest pain and some cough, and this is his radiograph. He was admitted, started on vancomycin and Zosyn, but he also had a BAL, and here's a CT. So it's kind of it's kind of localized to this. It's very segmental. It's very much localized right around this airway here. It seems like this segment here is completely uninvolved. But I just found this interesting. They biopsied it and cultured it and grew blasto.
Yeah.
which
Oh.
Jeff sees all the
I
time.
was
But
wondering, you're going to say blasto. I mean, it is endemic in the southeast. It's just very uncommon there. It's just so much less common away from the.
we almost never see it. That's why I found this one.
Yeah, I saw one case in Ohio. I biopsied it because it looked like a lung cancer. Now I see it all the time, and the air bronchograms are helpful. The presentation is usually somewhat helpful, but it looks really ugly.
So is this pattern? I was going to look through some of your cases that you've shown, but is it usually this segmental type of?
Yeah, I mean that's a smaller, but that's a pretty typical appearance. I mean that's when you showed it and it wasn't a cancer, right? That's when I figured it was going to be blasto.
Yeah,
it has that look.
and
Sometimes it's more larger and cavitary, but
yeah,
that's a nice case.
Very
Jeff,
nice.
Jeff, you made the point that there's not much lymphadenopathy and pleural effusions are rare with blasto.
Right, and when present, they're usually small, and the lymph node enlargement is pretty modest at most. Whereas with histo, you tend to get disproportionate lymph node enlargement.
Great. Yeah, interesting.
that's those are my three.
Perfect. All right. Well, it's at the hour, so thanks everyone. Those were great cases today. And next week is Thanksgiving, so we will not have a webinar. I am here the following Thursday. Is everyone else going to be available?
Yep.
Okay.
I will most likely.
Okay. We'll plan on 2 weeks from today then. And everyone have a great Thanksgiving and holiday.
You too.
If you're going to RSNA, safe travels.